Dear students, now in this session we will take ophthalmology. So the very first question is a chronic granulomatous inflammation of upper eyelid presenting as a painless swelling. Now what is this? Yes, everyone is right. This is chalazion, which is actually the involvement of the which glands? Can anyone answer which glands are affected here? Very good. So this is affection of meibomian glands, which are actually oil secreting glands. Yes, away from lid margin, very rightly said. Very good. And this is a painless condition as compared to sty, which is a very painful condition. This is a painless condition as compared to sty is painful and nearer to the border of eyelids. Okay. So meibomian gland affection, and you can see this is apical swelling, chalazion, and treatment wise what we can do in early stages, we can advise for hot, right? Because yes, Raghu, you are right. But before going for surgery, we should try at least a little bit of conservative measures, which includes hot compression, because we know that it is filled up of waxy material. So we just expect that if we do hot compressions, it might liquidify and come out. So we try with hot compression, yes, but if the condition is not responding, or if the patient presents late, then obviously we need to do the drainage. Patient is presenting late, then we need to use a chalazion clamp. We will give an incision and we will drain the things. Drainage. Perfectly fine. So this is the typical presentation for chalazion, and this is how we manage it. Now, next question. A child from low socioeconomic group, and he has foamy white spots over the temporal side of conjunctiva on both the eyes. So the description is actually for which condition? So the description is actually, yes, you are right. The answer is option D, that is vitamin A. And the condition which is actually discussed here is Bitot spots. Right? So the condition in discussion is Bitot spots, which are very well because A. Yes, Chiki, you are perfect. Deep, you are right. So this is vitamin A deficiency. Now next question, which of the following is not derived from surface ectoderm? See, crystalline lens is from surface ectoderm. Lens is from ectoderm. It's from surface. Any other answer? Yes, Aninda, you are right. You are right. The answer is sclera. And sclera is derived from mesoderm. Okay, the sclera is derived from mesoderm. Please remember, and rest other all options, corneal epithelium or epithelium of lacrimal gland, they are all phase. So this is in short about embryology. Now, which area is known as the dangerous zone of the eye? Yes, absolutely right, Raghu. This is ciliary body, and I think most of you must be knowing why we call ciliary body as the dangerous zone of the eye, because if there is any penetrating injury in the region of ciliary body, which condition will result? Here. Very good, Raghu, very good. This can result in sympathetic ophthalmitis. Okay, this is sympathetic ophthalmitis. Okay, so that's why this is known as the dangerous area of the eye. Now, you must know two more dangerous areas in the body, and one is dangerous area of face. Yes, anyone? And second is dangerous area of, yes, anyone? What is the dangerous area in face? Yes, Raghu, you are right regarding scalp. What about face? Very good, very good. So suppose if this is face and then this all area known as dangerous area of the, this is the dangerous area of the face. It is a, yes, yes, absolutely right. Pratik, you are also right. So this is the dangerous area of the face, and why we call it dangerous area of the face? Because infection anywhere in this part can directly go to the cavernous sinus, and it can result in cavernous sinus thrombosis. Okay, that's why it is known as dangerous area of the face, because there is valveless communication. Here, valveless communication between the branches of the facial. Yes, yes, oh, absolutely right. So because of the valvulus communication between the facial veins and the cavernous sinus, so that infection anywhere from here, it can directly reach up to cavernous sinus, resulting in cavernous sinus thrombosis. Okay, so that's why any infection in this particular area should be promptly treated, and just to avoid any possibility of cavernous sinus thrombosis. Now my question is, what is that important clinical feature which suggests possibility of cavernous sinus patient? Clinically, how you would suspect a given case has probably gone into cavernous? Any idea? If there is simultaneous involvement of, you are partially right. If there is simultaneous involvement of which cranial nerves? Third, fourth, and sixth. Right? Because these all are lying in relation to the cavernous sinus. Right? So if there is any involvement of cavernous sinus, the form of thrombosis, these all nerves also get affected. And therefore, if you see a case of person with simultaneous involvement of third, fourth, sixth cranial nerve, yes, along with proptosis and other feature of cerebral cranial infection. Apart from that, in terms of nerves supplying the extraocular muscles, particularly 3, 4, and 6. Think of cavernous sinus. That is a very unique situation where we see involvement of all the 3 nerves at one time. Otherwise, it is very rare to affection of all the 3 nerves. Right? So this is one important presentation which make us suspect the possibility of cavernous sinus. Yes, everyone is right. Aninda, Pratik, all everyone is right. Right. So this is dangerous area of face. I think this one is clear. Now we come to dangerous area of scalp, and yes, somebody already has already mentioned about this. Yeah, Raghu, you told about it. So if we yes, very good. So if we take the layers of scalp, what are the layers of scalp? S is for skin, C is for connective tissue, A is for, and L is for loose areolar tissue, and of course the 5th one is, yes Raghu, perfect, is pericranium, or you can also write periosteum, right? So these are the 5 layers. Out of these 5, we are interested in discussing loose areolar tissue, because this is the point of connection between the extracranial and the intercranial veins, right? Yes, Prakashi, Prakshi, and you are absolutely right. So this is the loose areolar tissue, which is the dangerous area of the scalp, because the intracranial veins, they communicate with the cranial veins, and if there is any infection in this particular area, it can directly go inside the cranium, right? So that's why we consider it as a dangerous area. The infection can move inside the cranium. Okay, so please remember these dangerous areas of the body: eye, face, and scalp. Next question. Placido disc. Yes, placido disc is used for detecting all except one A. No, it is done for A. A is we do it, we evaluate A. So this is right option. No problem. No, it's slightly difficult to answer. Actually, what we do in placido disc, we actually look at the surface of the cornea. So if there is any abnormality in the surface of the cornea, obviously it would be reflected in the placido disc. So just to make you understand the concept in a better way, you should look what actually we do in placido disc. So normally if you look at the corneal surface through a placido disc, it should show us a symmetrical and a spherical picture. So this is normal cornea, and if there is any distortion in the shape of the cornea, it may be because of keratoconus, it may be because of astigmatism, or even it is because of corneal scar, it will distort the image of placido, right? So placido disc, you can simply remember it is for corneal case, in simpler words, right? So therefore we can exclude the microcornea from these options. And now what actually microcornea is? What is microcornea? As the name suggests, micro means small. This is small. So the the horizontal diameter of the cornea is about 10 to 11 millimeter. Right? So this is microcornea, and this can be measured by caliper or ruler. Right? So microcornea is a different entity, and it won't show any irregularity on the face of the cornea. Yes, it is a congenital anomaly. It may be associated with a flat cornea also. So as far as the placido disc is concerned, any abnormality in the surface or the curvature of the cornea, you can say, that will lead to the distortion of the image on the placido disc. Clear? And I think all of you must be knowing what astigmatism is. There is a spherical aberration, so that the rays of the light, they focus on different point on the retina through the cornea. And keratoconus, as the name is, the word conus is here. Now the word kerato is for cornea, conus is actually conical. Right? So rather than, this is the normal cornea, and in keratoconus it becomes something like this. This is okay. So forward projecting conical type of cornea. Clear? So placido disc has no role, microcornea. Now next question. A child was hit while playing. He was hit in the eye, and later on he developed headache, diplopia on looking up, and inophthalmos, most likely diagnosis. Very good, Raghu. This is fracture floor of orbit. Now, before answering this question, we should take few words. Diplopia means double vision. Yes, Varun, you are right. And what is this word enophthalmos? Enophthalmos means, in simpler terms, you can understand it as sunken. So if there is sunken eyes, if there is diplopia, especially when the patient tries to look upward and associated with headache, post-injury, this goes in favor of the diagnosis of blowout fracture. And yes, the usual type is fracture of floor of orbit. Rakshi, inward eye, it's like sunken eyes, right? You can say inward eye, but better is sunken eye. So this is a typical case history for blowout fracture. Now, in ophthalmos, you will also find in Horner syndrome. In ophthalmos is also a feature of Horner syndrome, right? And what features you will find in Horner syndrome? Any idea? Apart from, okay, one is of course in ophthalmos, sunken eyes. What else will you find in Horner syndrome? Any idea? Very good. Anhidrosis, meiosis, very good. So one term is loss of sweating, that is known as anhidrosis. Then there is pupillary constriction, that is known as meiosis. Meiosis. Then there is drooping of upper eyelid. This is known as ciliospinal reflex. Very good. That is loss of spinal. Now, what is this loss of ciliospinal reflex? Actually, what happens if you pinch at the nape of neck? There should be pupillary dilatation. Now, what is the cause of Horner syndrome? Any idea? What is the cause? Hey, Raghu, is more related to sympathetic, yes, sympathetic ganglion injury. Yes, you can. Right. So, because if you see now, can anyone tell me why in sympathetic injury we are getting this ptosis? Why we are getting ptosis in a case of sympathetic? Yes, pancreas tumor can be very well related to sympathetic. We are right. And now this ptosis is because of paralysis of one muscle that is known as Muller's muscle. There is paralysis of one muscle that is known as Muller's muscle, and therefore we see. Okay. So this is all sympathetic system. Yeah, Muller's muscle. Yes, right, Chiki. So this is all sympathetic system dysfunction, that is Horner's. Clear? Anyway, so the answer to this MCQ is blowout fracture. Now, use of keratometer. I think everyone can answer this. Keratometer. Yes, curvature of cornea. Absolutely right. Curvature of cornea. Now, what for measuring thickness of cornea? Yes, B is correct answer to that MCQ. What is used to assess the thickness of cornea? Anyone? Instrument, wonderful, wonderful. Achymeter is used to measure the thickness of cornea. And what about the measurement of corneal cell count? Anyone? This is specular microscope. So these are some instruments to evaluate cornea, either curvature, thickness, or the corneal cell count. Anyway, keratometer for curvature of. Now, for measuring intraocular pressure, gold standard. Yes, Raghu, you are absolutely right. That is Goldman applanation tonometer. Like usually in, yes, everyone is right. It is B. Usually in routine OPD or otherwise we use Scheidt's tonometer, which is the commonly used instrument to measure intraocular pressure. But there is always some error because of the concept of scleral rigidity. Right? So there is always some. So that may give a little bit of erroneous reading at times, because if the sclera is thickened, it will show you little higher value. So in that case, your exact intraocular value, pressure value is not shown. It is on slightly on the higher side. Now, if we are using Goldman applanation tonometry, then this thing is ruled out. Right? Rule out the concept of scleral rigidity, and we get more accurate value for intraocular pressure, and therefore we prefer Goldman applanation tonometer. Everyone right? Now, if pterygium is occurring again and again, what you should do? So, for the prevention of recurrent pterygium, what we can do? Yes, perfect. We can try MMC. So, chemotherapy with MMC. This is mitomycin C. Yes, and yes, Daniel, Aninda, you are also right. Initially, we should do a conjunctival autograft, and then we should start MMC. So, in one sense, A plus B seems a better answer. But I think if you have to choose between A and B, then B is a better answer than A, because A alone will lead to recurrence again. So, there is possibility of recurrence again with autograph alone. Yes, if we do both together, then that's better. But if they are given as separate entities, then obviously mitomycin C should be given preference over the surgical procedure alone. Clear? So the ideal answer would have been conjunctival autograph plus mitomycin C. But in case if both the options are different as given in this question, then I think B is slightly better than, because mitomycin C is exclusively used in cases of recurrent cases of pterygium, right? So based on this concept, I think B is better than A, although A can be right. We won't say that A is absolutely out of the context. It is not so. A plus B is the ideal management for managing recurrent. A is also okay, but B is better than A. But ideal answer should be A plus B. Please learn it like that. So I think question actually needs some correction or correct framing. So here you can see there is this pterygium, which is, no, pterygium is pathology of which structure? Idea? Pterygium is degeneration of which structure? Conjunctiva. Wonderful, wonderful, Kushagra. So this is conjunctiva. And yes, on the advancing edge, Raghu, you are absolutely right. We can see a Stocker's line on the advancing. On the advancing end, we can see a Stocker's. Perfect, perfect. So this is pterygium. If we discuss pterygium, there is one pterygium of nails. Which skin disorder is related to pterygium of nails? Any idea? Wonderful. This is lichen planus. Very good. So the moment you find the word pterygium of nails, think of lichen planus. Yes, wonderful, wonderful. Everyone is right. Lichen planus. Anyway, coming back to ophthalmology. Now, a person has gritty sensations in both the eyes. Schirmer test shows 5 millimeter recording in both the eyes after 5 minutes. What will you do in this case? Very good, Pratik. Bhuvna, very good. Nilesh, you need a bit of correction. Now, firstly, we need to make the diagnosis. Gritty sensation means foreign body sensations are there. And then Schirmer test is showing 5 millimeter. Normal value for Schirmer test at the end of, what is the normal value for Schirmer test at the end of 5 minutes? It should be around, anyone? Very good, Kushagra. Yes, so it should be 10 millimeter. Now here in the given case, we are seeing that it is only 5 millimeter. Right? So what we need to do, if we put both these facts together, we will get a diagnosis of dry eyes. Very good, all of you are correct in this regard. So foreign body sensations suggest that there is dryness of eyes, which is verified by the Schirmer test, which is showing decreased tear production. So whenever there is dry eye, we need to supplement it by lubricants. Dry eyes give lubricants, right? So lubricants is the correct answer to this MCQ. Now, polymorphic neutrophilic infiltration is not seen in. Any idea? Neutrophilic infiltration. When we use the word neutrophils, we are actually considering something bacterial, some entity which is bacterial in nature. So based on that, can you get the answer? Yes, absolutely right. There is no way you can have neutrophilic infiltration in a case of allergic disorder, right? So yes, everyone is right. B. So whenever you find the word neutrophil, always and always think of bacterial entities, right? So neither allergic nor viral, we don't find neutrophilic involvement there. This is as simple as that. Now, a young female was using contact lens since many years, and now she is complaining of having foreign body sensations in the eye. Yes, Pratik, you are right. That is allergic. So yes, long-standing history of contact lens use, it can lead to giant papillary conjunctivitis. So giant papillary conjunctivitis on prolonged contact lens uses. So giant papillary conjunctivitis. Phylactenular conjunctivitis, any idea? Phylactenular conjunctivitis. The term phylactenular conjunctivitis, it is associated with, wonderful, Mycobacterium tuberculosis. So it is associated with Mycobacterium tuberculosis. So we will say that it is a tubercular entity. Please remember phylactenular conjunctivitis for Mycobacterium tuberculosis, although it can also be associated with Staphylococcus aureus. So as such, it is an bacterial entity, but we also associate it with Mycobacterium. Yes. Yeah. A 4-year child with complaints of reddening of eyes, and parents say that this condition recurs mostly in the summers, and on examination there was stringy ropey discharge. Now what could be the diagnosis here? Yes, I think this is a very basic question. The answer is vernal keratoconjunctivitis. Right? So this is everyone right. This is vernal keratoconjunctivitis, which is also known as spring catarrh, and the name is spring here, right? It is spring here, but this condition is seen in summers, right? It is seen in summer season or hot season. And what we see, what are the clinical presentation, what we find? Yes, Horner Trenta spots, very good. Clinical features, child usually or the patient usually have itching, okay, associated with reddening or photophobia. Okay? So itching is very important here, right? And yes, on examination, what we will see? On examination, ropey discharge. Yes, it's already mentioned, ropey discharge. Apart from that, we will see Horner Trenta spots, which are, what is the location of Horner Trenta spots? Any idea? What is the location of Horner Trenta spots? They are present at limbus. Very good. They are present at limbus, and limbus is actually the corneoscleral junction. They are present at limbus. Yes, perfect. And then what we will find in palpebral conjunctiva. This is at limbus. Palpebral conjunctiva will show you what it will show. Cobblestoning. Very good. Very good. It will show cobblestoning of conjunctiva. Very good. So please remember this much. And the clinical term is Maxwell-Lyon. So this is Maxwell-Lyon sign for ropey. Very good. So this is in short about vernal keratoconjunctivitis, which is also known as spring catarrh. Now, dendritic ulcers. Any idea where we see dendritic ulcers? Yes, yes, absolutely fine. All of you are correct. So this is herpes simplex keratitis, and if you look at the picture, it is very easy to identify dendritic ulcers of herpes simplex keratitis. Okay, this is herpes simplex. Very good. So dendritic ulcers. Now, herpes simplex involvement of eye, what you will not see. What you will not see in the case of herpes simplex eye involvement. Perfect, perfect, Raghu, perfect. You won't see purulent discharge because, yes, Nilesh, very good, Pratik. purulent discharge is not seen, because whenever you find this word purulent discharge, you are mostly talking about bacterial infection, right? So herpes simplex being a viral entity, it will not show you purulent discharge. Clear? So herpes simplex has nothing to do with purulent. A young female had an injury to the eye with a leaf, vegetable matter, and now she is having pain in the eye with photophobia, and we can see hypopyon with satellite lesions. Perfect. So photo means light, phobia is fear, and this is vegetable matter. So a very classical presentation of a case of fungal keratitis, and the classical and the most important clue in making the diagnosis is satellite lesions. Now satellite lesions means there is one main lesion and surrounding that there are small lesions, just like a planet has the satellites revolving around it. So similarly, main lesions and small peripheral accompanying lesions, which are known as the satellite. So yes, very good. So vegetative, yes, vegetative matter, that is leaf or plant matter, you can say, right? Classical case of fungal keratitis. Yes, young male with defective vision and irregular astigmatism, which is not corrected with glasses. What can be the answer? Raghu, yes, you are absolutely right. You are absolutely right. This is keratoconus, right? So we have already discussed what keratoconus is. In keratoconus, yes, what points you can write about keratoconus? There is conical projection of cornea, and the curvature of lens is increased. Not lens, cornea. This is cornea, okay? Not because the word keratocornea. No problem. And what will happen here, because of the change in the curvature, so there will be irregular astigmatism. Very good, very good. There is irregular astigmatism. Then importantly, if you tell the patient to look down, what will happen? This is Munson sign. What is Munson sign? Walks try, it's okay. If you suppose if there is conical projection and if you tell the patient to look downward, so what will happen? The lower eyelid will get indentation. So there is a V-shaped indentation of the lower eyelid the moment the patient tries to look downward. So on downward gaze, there is V-shaped indentation of lower. So this is in short about, yes, Pratik, you are absolutely right, V-shaped lower eyelid. We can also see fissure rings and all, but this is the core summary for keratoconus. So please remember this one. So this is keratoconus. So if I ask you which is not a feature of keratoconus, your answer would be very good. Fissure rings are not. It is only the fissure rings which are seen. Now, whenever you find the word fissure rings, obviously your answer has to be you find this particular word, your answer has to be where we find KF rings or yes, Aninda, you are right. Fissure rings. Where we find fissure rings? Wilson. Very good. It is seen in Wilson is also known as lenticular degeneration. So these are rings in the Descemet membranes. Yes, yes. In the, you are right. ATP7B gene. Yes, are in deposition. So there is deposition in the Descemet's membrane of the cornea. I think you are right. Right. So this is Keshav-Fleischer ring. It has nothing to do with keratoconus. In keratoconus, we can find Fleischer rings. Right. We can find Fleischer. Don't mix up with Fleischer rings of keratoconus with Keshav-Fleischer rings of Wilson disease. Yes, and in the Descemet's membrane, this is in Descemet's membrane of cornea. Yes, perfect. Yes, Raghu, you are absolutely right. Fleischer rings in keratoconus are in deposition. In Stocker's line in pterygium in the advancing edge. So, next question: perforating injury, which can lead to sympathetic ophthalmitis, involves ciliary body. So always and always, please remember, it is perforating or penetrating injury. So it is perforating or penetrating injury, and therefore we call it the dangerous area. Clear? Sympathetic ophthalmitis. Yes, everyone is correct. Caffeine, Chiki, Aninda, Pratik, Amir, everyone is right. Perfect. Now, this is a good question. Which of the drug is useful in acute uveitis? Yes, all of you are correct. So in acute uveitis, we should give atropine, and also we should give steroids. But atropine is very valuable for two reasons. Number one, it will cause mydriasis, okay? And this mydriasis will relieve the pain, okay? And also this mydriasis will break synapse if they are newly formed. Now this is very important. If they are newly formed, then only it can break. If they are little old or if they are consolidated, this is of no help. Right? Of course. So pain relief and breaking of synapse. Now what is the site of these synapse formation? The synapse forms between which structures? Suppose this is the lens, and in the front of lens we know that there is iris. Yes. Then here we have ciliary body. So what happens? The addition formation occurs in anterior part of lens and the posterior part of iris. So posterior part iris, anterior point of formation of the synapse. And therefore what we do, if we give mydriatic, they will dilate the pupil. It means the iris will move like this, and whatever synapse has been formed will break. So that is the principle behind giving atropine in a case of acute uveitis, and it has to be supplemented by steroids, which is anti-inflammatory. It also helps. Here we are addressing two important problems: pain and this synapse is very problematic. If it is not addressed properly and timely, later on it is beyond management. So synapse has to be broken in the early phase only. So this is very important. Please remember atropine for acute anterior uveitis. Now next question: depth of anterior chamber is reduced in. Depth of anterior chamber is reduced in. Yes, Raghu, you are absolutely right. This is angle closure glaucoma. Now, I think all of you must be knowing what is glaucoma. Glaucoma is raised intraocular tension, and we have two types. Very good, Raghu. So we have two types open angle and closed angle, or what we say angle. Now, what happens in open angle? Now, firstly, you have to understand what actually the word angle is here, right? If you see, if this is iris, suppose this is iris, then here we have cornea, and here we have the drainage channels, that is the Schlenz canal, or right. So this is iris, this is cornea, and these are the trabecular meshwork, which is important in draining the aqueous humor, right? So what happens in open angle glaucoma? There is pathology in trabecular meshwork, right? So this drainage channel is at fault. The anterior chamber or the angle of anterior chamber, it is okay. It's just that the trabecular meshwork is at fault. But what is the pathology in closed angle? In here, the trabecular meshwork is okay, but it is just that the cornea is so close to the, so close to the iris, and this angle is so narrow that the aqueous humor doesn't get space to reach up to the trabecular meshwork. So what you write here, decrease depth of anterior chamber, so the aqueous could not reach up to the trabecular meshwork, right? So depth of AC is reduced in angle closure glaucoma. Is that clear? And since the cornea is in so close proximity to the iris, there is the outflow tract of the aqueous is almost blocked. So what we need to do here, we can do iridotomy, and in older times we used to do peripheral iridectomy, used to remove a triangular portion of iris so as to create a bypass for the humor. We have to create a channel so that the aqueous humor reaches up to the trabecular meshwork. This is the basic. Yes, Shubham, you are right. Outflow of aqueous humor is obstructed, and therefore, since there is no drainage, intraocular tension rises. Very good. So please remember this one for angle closure. Now coming to microaneurysm, where you find them? Yes, so this is diabetic retinopathy, and it is one of the earliest feature of diabetic retinopathy. Clear? Microaneurysm. Now, a known case of diabetes presents with painless visual loss, and when we examined the fundus, we saw blood and thunder fundus. Blood and thunder fundus. Any idea what is this? Very good, very good. So this is CRVO. This is CRVO. We will see all red and yellow. That is blood and thunder fundus, very suggestive of CRVO. Yes, tomato splash is also okay. Yes, everyone is right. CRVO. Please remember blood and thunder flash. Or next question. A child was brought with decreased vision. On examination, we can see a white pupillary reflex and a cauliflower-like mass with calcification growing out from the retina. So the description is, there shouldn't be so much of confusion for this question because it's a very basic question. And what is very specific for the answer is white pupillary reflex, right? So white pupillary reflex, which is also known as amaurotic cat's eye reflex. And here, when we do fundus examination, usually we have all that red glow kind of impression. But because of this tumor, that area will remain white. So that is known as white pupillary reflex or ameretic cat's eye reflex, and this is one classical finding. The moment you find this word, the answer has to be retinoleucocoria. Perfect. So please don't err on this, quite forward question. And in a child, so if you write like most common intraocular tumor in a child, answer has to be retinal. Rhabdomyosarcoma can present with cauliflower like mass, but white pupillary eye reflex is very indicative of retinoblastoma. So this is retinoblastoma, cauliflower like mass, and giving rise to ameretic cat's eye reflex or leukocoria. Right? So this is retinoblastoma, and here you need to just remember few things more, like what we will see on histopathology. What we'll see on histopathology? Any idea? Wonderful, wonderful. So we will see rosettes, and it can be, Winter's Steiner or Homerite. Right? So we will see Flexner, Winter's Steiner. Yes. So Homerite rosettes. Rosettes or sometimes pseudo rosettes have anything. So please remember these words on histopathology. And whenever you are doing treatment, always explore the optic nerve for any chances of tumor invasion. So do explore optic nerve. So retinoblastoma is one of the important tumors. Please read about it. And the classical and the most important clue is leukocoria. The moment you find this word, white pupillary reflex, leukocoria, ameretic cat's eye reflex, no need to go here and there. Blastoma. Okay. Chalo. Then last question for this session. A person has inability to look downward and laterally. Which nerve is gone? Now there are two terms, and both have to be included in your answer. Now before that, we can clearly rule out trigeminal. It has nothing to do with muscles or movements of the eyeball. So you can rule out option D. Now we will take the options one by one. Now many students are saying so oculomotor nerve, it supplies SO4, perfect, LR6 and rest. Now here we have to include two movements. You are absolutely right, Aninda, you are absolutely right. Actually, which muscle we are talking here? Because there is one muscle which have both these actions, downward, lateral. Which muscle is this? To get to know the muscle, you will get your answer. So which muscle we are talking about? Wonderful, wonderful, Raghu. This is superior oblique muscle. Yes, this muscle is actually superior oblique. And what are the actions of superior oblique? You know, one of the action is abduction, right? This is the abduction. Then another is depression. You can see this is depression. And third is intorsion. So these are the three functions of superior oblique. So obviously in the question we are given two of the functions which are gone. So based on that, we can presume that this question is actually discussing superior oblique muscle. And since we know that superior oblique is supplied by trochlear nerve, so the answer would come out to be trochlear nerve. So here we cannot take the two options in isolation. They both have to be considered together. If there would have been only, say, downward gaze, then we could have gone for SO, or we could have gone for inferior rectus. Or if there is only about lateral movement, then we could have gone for SO plus LR. But here we have to include both the facts, downward gaze and lateral gaze. This is better explained by the paralysis of superior oblique muscle, which is supplied by. So I hope you must have enjoyed the session. We can have a little break and then we will continue with the last chapter for today. And again, it is surgery, so it is going to be a little time taking. So please recharge yourself. See you on the other side of the. Thank you.